All right, welcome everyone to this new panel on the future of AI optimized hospitals. My name is Jean-Philippe Wirtz. I'm a CEO of Vayalil, a startup based in Europe and the US developing AI solutions for healthcare. And I have a great pool of panelists here, whom I will ask maybe to introduce themselves just by their name, what they're doing, and maybe very quickly to start off the discussion, telling us one thing, one aspect where they believe AI has already impacted hospitals or healthcare.
Hi, everybody. Good afternoon. So lovely to be here today. My name is Temie Giwa-Tubosun. I am the founder and CEO of LifeBank. LifeBank is essentially improving the quality of care in hospitals across Africa. We operate about 3,000, we partner with about 3,600 hospitals in 4 African countries, helping them optimize their supply chain, their finances, and essentially entering a partnership to improve the quality of care.
All right, thank you. Robert Masson, eXeX, surgery intelligence company. You know, in hospitals right now in the US, which is my canvas, it's so brand new, the primary use is really to organize workflows to improve fundamental human-based tasks. I think there's a lot of long-term impediment towards rushing too fast with AI. So there's a gentle push, but we're definitely seeing it improving the human side of healthcare.
Thank you.
Hi, my name is Kingsley Ndoh. I'm the founder and CEO of Hurone AI. Think about us as that company that is making cancer care more human again. And we make cancer patients connected to care. We build an intelligent AI co-pilot that supports cancer patients to navigate their symptoms and their side effects and match them to resources. And we are in the business of ensuring that AI can be trusted, and AI is not just the front and center layer, but is that undercurrent that makes what doctors and nurses enjoy, which is that humanness of healthcare. And we're doing that with cancer. We're focused in the US. We're working with large cancer centers in the United States, co-creating and implementing with them. And really honored to be here.
I am Dr. Shamsheer. I'm into both healthcare and education. The healthcare company is called as Burjeel. This does primarily hospitals, which has got more than 2,000 physicians working across GCC and Africa. We have a pre-hospital care company which does emergency onshore, offshore. So our clients are oil and gas, energy sector. We look after more than 1 million lives across. We have a unit which is into combat medicine training. So pretty unique in our offerings. We look after pilgrims like Hajj and Umrah. We look after mass gatherings. So that's a paramedic emergency-based business. Our education vertical comes under Amanat Holdings, which is into special needs and higher education. So we are across education and healthcare, and I think the most important thing to connect all these things are the new tools that comes out, and we can talk about it as we go.
Excellent. So to start some topics about this discussion, I'd like to focus a bit on some geoeconomics or risk of health inequities in the world. So I think we're in a situation where we see a possible divide between, in some African countries, some advanced AI systems scaled in modern hospitals. In more emerging markets, we see other AI-based solutions to fill the gaps for the lack of resources. Right. Think of, for example, fast, X-ray screen systems to diagnose tuberculosis, etc. So how do we deal with that situation, the risk of divide that increases of inequities? And maybe I will start with you, Temie. So you're already working, at the intersection of AI and, last mile logistics, how to bring the treatment to patients. So according to your experience and your view, what's the fastest way for emerging markets to fill the gaps in patient care delivery with AI?
Thank you. That's a fantastic question. So the way we think about hospitals is that right before I came to this panel, I was looking at the research, and Lancet released some really alarming facts that about in lower to middle income countries, they lose about $6 trillion from their GDP annually because of poor quality care delivered in their hospitals, right? So this problem is very acute, it's very urgent. It is morally just because by improving the quality of care, you can save about 8 million people in lower to middle income countries. And not only is it just morally right, it is absolutely economically sound decision. This conference is about prosperity, and we really believe that lower to middle income countries must not just be a net benefiter of economic aid, but we can also participate in global ingenuity, in global growth, by displaying our own way of doing things. One of the interesting things, LifeBank serves about 3,600 care centers across Nigeria, Kenya, Ethiopia, and Sierra Leone. And one of the fascinating things we've learned about how our care centers are deploying technology is the way that it saves time and cost by improving clinical processes, by ensuring and confirming that care providers are following clinical plans, personalized clinical plans, and also improving the operational efficiency of their system. One of the ways that we've been able to do that is use data, clinical data, operational data, to build an AI platform that basically serves as a co-pilot, a co-manager of a hospital. Essentially, a manager of a hospital gets to work in the morning, sees all the data, and then there's an agentic AI built on this ERP system that basically communicates what changes they need to make to ensure that they are able to deliver high quality care at the cheapest rate possible. So I think that while there is a disparity in terms of resources that are available, I think the exciting thing is what we do with that, right? That forces our hospitals to be more efficient, to deliver great care at a very, very affordable price. And that is lessons that I think health systems globally can learn from the type of work that is happening in lower to middle income countries.
Very, very good. Maybe to the other panelists, so on this question of equity, could you quickly share what you believe is the most significant risk of inequity when, in a sense, the most advanced technologies, life-saving technologies, are concentrated in the wealthiest nations?
Yeah, I mean, in the surgery space, it's pretty clear it's the technology cost and the infrastructure support. So we deliberately out of the gate came with consumer-based products, and we're using an Apple. We're technically agnostic to hardware, but on the other hand, we want user interface, compatibility, and simplicity, and really easy to acquire systems. I did a Nepal mission trip in our alpha year, where we were using the Apple Vision Pro in live surgery halfway around the world off 5G, and using our digital twin to map and score the surgeries there. So it makes it affordable and portable.
Kingsley?
So I think I'll answer this question looking at my background. So before I became an entrepreneur, I used to be a clinician. So I have seen disparities up close. I also advised President Biden's President's Cancer Panel on cancer technologies, and a lot of the work we did was really looking at how we can make these technologies more equitable. And so in building any AI, especially that is patient-facing, we need to have very strong governance frameworks. And for our company in Hurone AI, we've done that with our partners. So we're partnered with large academic systems that we co-create in governance in ensuring that we can look at things like bias, we can look at things like what kind of intuition will an older patient have for using this technology versus a younger, more tech-savvy patient. The key thing we have to really look at, even in a high-income setting like the US, is to ensure that we are building systems that are not increasing already existing disparities, but are addressing disparities that are already existing in the healthcare system. And that's how we view it as a company.
Thank you.
If you look at AI, I don't believe it can reduce the cost from day one, because any new technology is going to be expensive, and until and unless it's designed to scale. So again, the purpose has to be clear, because if you try to play off the shelf, bring it to address the disparity, and I believe African continent is big in terms of manpower shortage. infrastructure shortage, communications. We operate in war zones. So we have some of the hospitals with Starlink, and we are on the new version of the AI EMR by Oracle. So I think it has to be a purpose-driven, and I don't think AI alone can optimize hospitals. It has to be intelligent people designing the AI to make it more optimistic. So I think the speed of the organizational culture, because when you introduce AI, there's a lot of resistance, especially by the physicians.
Right.
They first think that it's going to take away their jobs, and that's how AI is positioned. And if you talk to public, they'll talk about their experiences by going to a lab and saying that I don't see a doctor sitting in that chair for too long, but we see that most of the repetitive jobs can be put into efficiency by embracing AI. So it's going to be a very interesting play. It's not just the technologies that are coming out, it's about how we are going to embrace them, adapt them, integrate them. We cannot substitute. We need good manpower. There's a big shortage across. So training people, changing the curriculum of physicians. So again, a lot of challenges because our physician curriculums are age old. And they come out and then they start hearing about AI. AI is everywhere right now. So it's going to be a very big cultural shock for physicians to embrace unless and until it's designed into the fabric of the system.
Thank you.
Yeah. Can I touch on that?
Yeah, sure.
Yeah, in the surgical space, surgery is really resistant to change, and trust is imminent at probably the highest level within hospitals. So we're very much starting with surgeon advocacy. We're absolutely humanistic. We're absolutely giving it to them for the purpose of reducing their administrative work. We're not going in guns blazing with a total solution to change surgery forever. It's to enhance the human performance of nurses, of scrub technicians, of the support crew, radiology techs, the entire orchestra to each surgery. And it's going to take a while to build systemic trust. And AI isn't really ready for surgical healthcare, particularly healthcare at large, I would argue. It's really immature right now. And the models aren't properly trained yet. And in no way can we really trust that. So trust being the key word, we go in with high surgeon advocacy and trust as our number one priority.
Just to piggyback on what he said, because you're a neurosurgeon, you operate in the neurosurgery space. One of the institutions we work with is UCSF Brain Tumor Center. Right. And one of the things that we showed, so a lot of times when patients, after post-op care or pre-op, when they're trying to figure out like what are all the things I need to do or what are the things I need to do after surgery, they send all these messages and it's in through the patient portal and it's in these in-basket messages. Sometimes there are 20,000 nurses are just answering the same thing all the time. And one of the things we did with UCSF that we showed was that it reduced that in-basket message by 80%. Now, that means that a nurse can now go there and deal with more complex things, or a doctor can deal with more complex and more human things that they love to do. No one really loves mundane work. And the future of healthcare is not really, AI is coming to change everything. It's more of that seamless collaboration between clinicians, data and AI in the center, and patients. That seamless collaboration is what the future of healthcare would look like.
Absolutely. Just to add to that, I think I agree with everyone. Back in 2018, we launched an AI platform, basically a machine learning system that tracks the medical history of each patient and tries to determine who is going to need blood in a particular therapy. Because blood is very scarce in our context, and making sure that we have foresight ahead of that event was really essential. We launched it to fanfares. We partnered with so many care centers and hospital services, and basically the clinicians refused to use it. They simply said, that is my job, right? I am supposed to look at a patient and determine what the clinical action I need to take was it. So that was back in 2018. So one of the things, the insight we got from that was, okay, we'll pull back a little bit from direct clinical care, right? And then do a little bit more work in the boardroom, right? So hospitals have boardrooms, they have boards, and the boards want more efficiency. They want to make sure that the financial health of these hospitals are well cared for. So we kind of shifted our strategy from entering the clinical arena, right, which is going to have very significant pushback, and more focus on administration, like routine work, right, routine workflow. How do you manage your books? How can we ensure that your books are cleaner? how do we make sure that you can get investment, right? Imagine serving 3,600 hospitals and being able to, connect these care centers with the investments that they need by just figuring out how to build agentic AI that improves the way they do business and improves the way they care. And therefore saving them money and ensure that they can increase the quality of care. So that's how we sort of think about that significant challenge with providers.
So there's an interesting word you discuss, which is trust. I think you discuss a lot the trust of the users of AI, like how clinicians would trust a machine, etc. But can we deep dive a bit on the trust of patients?
Right.
Because I believe, today we're at a historical low in trust of patients in the healthcare systems. People don't trust vaccines, don't trust physicians, at least less than before. So there's a possible risk that bringing new technologies, especially black box AI, magical AI, could erode even more that trust. Is that something that you have experience with? So I don't know if I should start with Robert or whoever has some experience to share about not only the user, the professional users of AI, but the patients themselves.
Right. The teams in general, there's two types of AIs in surgery: surveillance AI and basically humanistic AI that is specific to the surgical field. The teams do not trust surveillance AI. They hate it. The administrators and the entire financial layer supports it significantly. When you get to the trust of the patient is more focused on what is the AI doing. If the AI is enhancing performance of the surgery, there's a significant trust. If the AI in any way is messaged improperly to the extent that it's implying that it's making decisions or executing surgery, and I have significant problems with AI doing autonomous surgery. That's not in my lifetime. Any technical failure is unacceptable. So it's really a tool to enhance the execution of the teams, and in that zone, it's completely trust. But you have to be very clear, and you have to be intelligent in how you convey it, and they have to believe you. So there's a human communication component that I think a lot of providers don't necessarily embrace, but all of it has to come together for it to be fully influent.
Kingsley?
So one thing that can really engender trust, and that's the way we're building, is by co-creating. You have to co-create with the user in mind. So a lot of what we're doing is co-designing with large academic cancer centers, understanding their workflows, understanding what clinical validation means to them. Those are the kind of things that drive adoption. If you look at Google searches last year, 10% was personal health questions. So patients are already, if you want to think about it from a workflow perspective, after a patient sees a doctor, before they see a doctor, they're asking Google questions. Now ChatGPT, when Sam Altman launched GPT 5.0, about 5% of queries were personal health questions. And we've seen that patients, if they're not an expert, they might not understand the full context to give to this generalist LLM. We've seen situations where a patient died of bromide poisoning because of what ChatGPT told them. So what we do is that end-to-end connection with the patient's medical records. Our system gets more intelligent with time, over time, with longitudinal data that the patient produces. And we really put the patient at the center of our model, our design. Very important for adoption, creating with both the clinicians, which includes nurses, social workers, doctors, and patients. And that's how you can build a system that is not over, like they're looking at several screens and over technology, but one that really fits into their workflow and they can see immediate value.
Shamsheer?
We believe AI is coming and it's coming. Whatever we say on the trust, people are so fast in embracing the new technology. Even if you see the local, the GCC population, they're very fast in embracing new technology. The problem is many of these things get designed in the clinical room, and the disruption is going to come from outside of the industry. So let's likes of Google, ChatGPT. So I think it's about time that we prioritize the needs and the demands, and it's very specific to the region, it's specific to the culture. So I think we need to have a very clear agenda, and it's going to come. Agentic AI, we are using heat stroke AI algorithms with Hippocratic AI, where we can literally make 1 million calls a day. And one of the biggest problem here is heat stroke and heat exhaustion. And the time they reach the hospital, it's passing that good opportunity to treat them. So again, it's about the use. People want it, and I don't think there's anything stopping from going into that direction. We have seen disruptions coming, and I think healthcare is always risk averse. If you put 5 physicians in a room and start discussing, we'll always try to make sure that we only cover the risks, but patients are moving faster. The new generation will use it much more diligently than any of us. So either we move fast or we're going to be having a tough time.
Temie, do you have ideas on how to build trust with patients?
Absolutely. I think patients actually already somewhat trust the system. And I think AI system create a sense of privacy, a sense of intimacy that maybe be missing in clinical care. One of the things that we noticed is lower to middle income countries, when a patient goes to a hospital, they only get about 5 minutes FaceTime, direct FaceTime with their clinician. That is not enough time to create that intimacy that allows trust to build. So I think healthcare itself fundamentally has a trust issue, and AI might exacerbate that or improve it, right? Depending on how it is rolled out. There, of course, newer generations, Gen Z, Gen A, they have an intuitive trust of this AI system. They like that closed structure. One of the research that I saw recently coming out of Nigeria was that a lot of young people were asking, reproductive health question from AI system because they felt like that is a neutral party they can trust. But I think what is important is to make sure that, like everyone has mentioned, that we need to build AI that is clinical. It can't be generalist, right? So when we're designing the system that people are going to create that intimacy with, that system must ensure that there is no harm done, right? And I think that is the danger of how people are using these systems.
Thank you. So, I have, of course, plenty of other questions, but as we're getting closer to the end, maybe I will just keep the last few minutes for you to have a last word. And my question would be, in 5 years, when we convene here, 2030, if we get this AI transformation right, what do you think the hospitals will look like? Temie.
I think hospitals of the future, and I'm really excited about it. I hope you guys can see that. Hospitals of the future, I think a lot of people assume it will look like big screen, blank rooms, sterile. I think it's going to be the opposite of that. I think hospitals of the future will be intimate, they will be colorful, there will be intimacy between the care providers and the patients, because we will allow AI to do the grunt work, to do the administrative task, to do the operational task, so that clinician will focus on what they do best, which is deliver care directly to their patients.
Excellent.
So I'm really excited for that world.
Yeah, in our case, what we're really doing at the bottom foundational level is codifying master surgeon expertise and collecting the data and perpetuating the data forward. And I think 5 years from now is where we start to see the eventuality of sending young surgeons, newly trained surgeons, off into the globe with fully equipped procedural platforms mapped out by their mentors, by their experts, by the generation of surgeons that built the transition of 1990 surgery to master surgery pre-robotic. The next generation is not going to have the subtlety and nuance of being able to do it without technology. So we're going to codify that and make that available. So no matter what, with failure of technology, there will always be a fallback for education. So,
thank you. Kingsley.
Yeah, in a world where the healthcare system is fundamentally broken and distrusted, and physicians and care teams are just overburdened, I see the hospital of the future as one where doctors, nurses, social workers, and everyone involved in patient care is now operating at the top of their license, because we have this technology layer that have sort of taken all that mundane tasks away from these clinicians. And I also see the hospital of the future as one where the longitudinal data of the patient, which means their wearable data, patient-reported outcomes, can really compound in clinical decisions that can make their lives better, and that can make precision and personalized medicine that we all preach about a reality in our time. Thank you.
Thank you. And last word to Shamsheer.
Yeah, I think it'll be more care in the community. With compute, AI, data, and research, I think many diseases will go extinct. We'll have a cure. I think that's going to happen sooner. So the designing itself will change, and hopefully better outcomes for the patients.
Thank you, everyone. Please join me in thanking all the speakers.
Thank you.